I know this interactive session is going to be interesting. So good morning, everybody. I have been told to show some ECGs and we'll have some interactive session in the form of a quiz. Thanks, Kavita, again. So this is the ECG number 1. What is going to be coming up? I'm going to be holding this ECG for a while before we start the discussion. So apart from Achu, there are 3 or 4 more residents must have logged in. So I am holding this ECG for another few seconds. This is a 14-year-old male. Now based on this ECG, I'm going to be putting up a few things which will tell you something more about this boy. He is asymptomatic. And these days there is a rigorous screening, especially when some high enduring athletic activities are concerned. So this boy is trying to participate in the national cricket team under 18 years of age. In the screening, this ECG abnormality made him to consult a cardiologist. So that's the background. So Dr. Rajesh, welcome. So this is the background: 14-year-old male, asymptomatic, athletic, wanting to participate in cricket, but he has to undergo screening tests. So with this information, if I ask, how do you risk stratify? How do you give the fitness on basis of what? Is it a Holter monitoring, a loop recorder? It's going to be a treadmill test, or to be on the safer side, you require all of the above. So Achu is correct in making a diagnosis of a short PR interval and a leftward axis. And he also says a loop recorder. The short PR interval, and the wide QRS, and the initial slurring on the QRS is telling you that it's a WPW pattern. So this WPW pattern may predispose the patient to have more often palpitations and very rarely sudden cardiac death because of atrial fibrillation conducted very rapidly to the ventricle, predisposing to have ventricular fibrillation, a very, very rare event. However, especially in an activity where high endurance is called for, it is considered relatively contraindicated. So to figure it out whether a WPW pattern in a boy 14-year-old, is it a risk for a sudden cardiac arrest? There are several tests that are proposed. The ideal test is an invasive test, an electrophysiology study. However, before subjecting to invasive EP study, one can also figure it out on the basis of changes that can happen during certain maneuvers. For example, a treadmill test. A treadmill test, if in the basal stage has pre-excitation, as the sinus rate increases, if the pre-excitation disappears, means the accessory pathway is not able to conduct at the rapid rates. So that is relatively a simple test, but several limitations attached to it. Till what rate, if it persists, the safety is not very clear. Whether it is a gradual transition from wide to narrow or an abrupt change, there's a controversy. But if the sinus rate increases beyond 100, 110, and if the pre-excitation disappears, it is almost certain that the accessory pathway is not able to conduct at faster rates, and hence, in case if the boy develops atrial fibrillation, it's very unlikely that he would develop a ventricular fibrillation because that AF may not conduct very fast. So the right answer is a treadmill test. Well, a loop recorder are two varieties. You were saying loop recorder. One is external loop recorder, which can monitor the rhythm for a varying period of time, 1 week, 2 weeks, and some loop recorders even can record up to several weeks. And there's an insertable loop recorder that can actually record the rhythm over a period of 2 years. Well, the yield may be high, but you are at least the insertable loop recorders are not of use, especially in asymptomatic WPW pattern, where you would like to assess the risk much early. A loop recorder is usually used when there are symptoms, and the symptoms are not frequent. They happen very rarely, and you are unable to record the event. So it is in a symptomatic patient where the symptoms occur very rarely is when a loop recorder is advised. Similarly, Holter monitoring, the yield is more when there are symptoms, but they occur infrequently. But we are dealing here with an asymptomatic person. In this, an invasive study or invasive study is not a choice here. Invasive electrophysiology study is not a choice here. And it is usually not recommended. It is extremely rare that an asymptomatic 14-year-old boy developing symptoms, including sudden cardiac, is extremely rare. So there is a hesitancy to subject these patients for invasive electrophysiology study. Among these, a treadmill test is what is going to risk stratify with several limitations. But among these choice, treadmill test is the one. And more often, it is quite reassuring. More than 70 to 80% of asymptomatic WPW pattern, especially beyond the age of 14 years and in adults, if you subject them, asymptomatic people subject them, you tend to see the disappearance of the pre-excitation. So the right answer here is a treadmill test. If there's any question from the participants on this. Okay, we go to the next. So this is another 14-year-old boy. I hold this ECG for a while. And then I show another ECG at another period of time. It is on 2nd May 2017. And this is, oh, it was both of the same. Okay. So if I show this ECG, and then if I give the choices, LVH, LVH and RVH, the thin built boy, most likely none of the above. So what it could be the right choice among these 4 choices? So can I see some responses? Okay, again, Achu is quite enthusiastic in participating. He says choice B, LVH and RVH. Yeah, if you have a tall R or R taller than S, it suggests an RVH. Similarly, if you have the voltage criteria, there are very large amplitude V5, V6. So it might appear that there is a right ventricular hypertrophy in V1 and the suggestion of a left ventricular hypertrophy. And if you have a biventricular hypertrophy You also try to see the axis, which is the leftward axis. It appears that there is an RVH and an LVH. However, in an RVH and an LVH, if it were to be there, the PR is either normal or near normal, but the PR interval seems to be quite short. And you have a delta wave, that's the slurring of the initial part of the QRS. So this is not necessarily the representation of hypertrophy, but it seems like it is a manifestation of a pre-excitation. A right bundle branch block pattern tells you, in the presence of a short PR and a delta wave, tells you that it's a left-sided pathway. A left-sided pathway may manifest as right ventricular hypertrophy and also left ventricular hypertrophy. So the abnormal ventricular activation, or what we call pre-excitation, may alter the QRS morphology such that it may mimic hypertrophy, it may mimic ischemia, it may also mimic the delta waves if they are negative, it may also mimic myocardial infarction. So whenever we look at some abnormal QRS complexes, especially if they are white, a pre-excitation needs to be ruled out. So here, this is not LVH, this is not LVH-RVH. These large and abnormal complexes are a result of pre-excitation, and that is due to the left-sided accessory pathway. A thin bit may cause increase in the amplitude to an extent, but it would not cause abnormal configuration of the QRS. Amplitudes can be larger, but the morphology, the characteristics of the QRS shall remain normal in a thin belt. Here, large amplitudes are there, correct, but the way the QRS are inscribed, they are abnormal. So the correct answer is none of them. Okay, so what has happened with this 14-year-old boy is that this pre-excitation, because of the left-sided accessory pathway, makes him predisposed to develop orthodromic tachycardia, and that is what was happening here. So this is the patient with the pre-excitation developing a regular narrow QRS tachycardia. And a regular narrow QRS tachycardia in a 14-year-old boy is more suggestive of a presence of an accessory pathway than either AVNRT or atrial tachycardia. I'm putting this ECG here because this boy used to have symptoms from the age of 6 years. And then this kind of a morphology, typically, say for example in V1, it always was considered as a sinus tachycardia. So it may appear as a sinus tachycardia, especially in a presence of an accessory pathway mediated tachycardia. One needs to be aware the presence of an accessory pathway, which could be manifest as in this case, or it could be concealed. This patient has had moderate LV dysfunction, maybe it is because he was having persistent tachycardia. So I am giving you another ECG and I hold it for a while. This is another 14-year-old boy. Well, I can give another clue that he had undergone surgery for congenital heart disease. He seems to be doing well. 2 years down his surgery, he is asymptomatic. Now, what is the answer? There are 4 choices given. Achu can again attempt this. So Achu has left. Okay, so I will carry on explaining this. What we are seeing here is, okay, Sakshi Sachdeva says all of the above. Sakshi says this ECG is representative of AV Venkibak, which is correct. For example, you have group to beats. For example, let's take this set, PR prolongation and a dropped beat. So we call this as a 3:2 AV Venkibak. This is 3:2 AV Venkibak. This is 3:2 AV Venkibak. Now, if these things are not to be there, and if it is only shown, you would have called this as a 2:1 AV block if these sequences were to continue. For every 2 beats, every 2 sinus beats, if there is 1 QRS, you would have ascribed this, or you would have called this 2:1 AV block. But this is an example that if it is a 2:1 AV block, it could also be a part of a Venkibak. So that's correct. AV Venkibak is correct. But the question is it a benign as well? Well, AV Venkibak blinded to this ECG and the history most often is benign. But now this AV Venkibak phenomenon is seen in this 14-year-old boy who has an abnormal QRS. This QRS is abnormal in 2 ways. It is white, representative of a right bundle. On top of that, it has a leftward axis. So there is a significant intraventricular conduction defect. AV Venkibak usually suggests the pathology residing in the AV node. But if this is also associated, this Venkibak phenomenon also associated with abnormal QRS, it suggests the disease can be a little more extensive, involving the His bundle or the infarct-deviant region as well. So this wide QRS and abnormal axis makes us to consider this not really benign, even if the patient is asymptomatic, especially if the history of intracardiac repair for a congenital heart disease exists. In the presence of a history of a surgery, if you also know that this has developed post-surgery, one should not consider this as benign, because this may progress to symptomatic CHD, and hence in this AV Venkibak abnormality, a pacemaker is strongly indicated. So the right answer here is just it is an AV Venkibak. This is not benign, and pacemaker is strongly indicated even though the patient is asymptomatic, because it's post-surgery, number 1. Number 2, wide QRS, abnormal axis. So I hope Sakshi now understood the malignant nature of this AV Venkibak. Any questions? All right, Sakshi. So now I think she got the points here. We go to the next. Okay, so this is an 18-year-old female. I'm holding this ECG and the questions here. What does this ECG representing? Is it a tamponade? Is it a pneumothorax? Could it be any one of them? Or sometimes, especially in a trauma, You can have both tamponade and pneumothorax, or none of the above. So Achu says tamponade. I hope Sakshi would respond to this. This is Sheikh Amira. Sheikh Amira says both possible. Sakshi says anyone on the above. So I think there are three responders here. At least two of them think there are both the possibilities. Achu thinks it's tamponade. Achu, are you going to change your opinion? Wow, he is quite defiant. Achu is sure that this is not pneumothorax. Really? Okay, so he's quite firm in his response. I like that. And Sakshi and Abhinav, and there was one more responder, Achu, Sakshi, Sheikh Amira. Now, any one of you would like to change the response? I'd like to see they also saying no. All right. Well, I liked the responder rate here, but I'm sorry that none of the four who responded are correct. The answer then has to be none of the above. Okay, now let's consider my argument why this is not any one of the above. All right, what is so remarkable about this ECG? There is a tachycardia. It's about 110, 120. There is tachycardia. But what is more remarkable is the low amplitude QRS complexes. In the limb leads, it's not even 5 millimeters. In the precordial leads, some of the leads are recording as small as about 1 millimeter. Okay, these are with respect to the QRS. The QRS amplitudes indeed are very, very small. Can we make the same qualification for the P waves? Is the next question. No. Indeed, the amplitude of the P waves tend to be within normal limits. And indeed, in lead 2, the P waves are actually taller than the QRS, and these P waves, even by normal standards, seem to be little taller. So there's a disproportionate reduction in the QRS amplitude. Preserve the P wave amplitudes. This discordant amplitude changes, P waves being unaffected, QRS remaining very much affected, cannot happen in tamponade, cannot happen in pneumothorax. This can happen in loss of myocardium. This 18-year-old female is suffering from severe idiopathic dilated cardiomyopathy. There is loss of myocardial tissue, which would have given rise to the QRS voltage complexes. So, if you have a discordant amplitude changes, QRS complexes significantly recording low amplitudes, relatively preserve the P waves, one should think that this is a severe dilated cardiomyopathy, and this cannot happen either in tamponade or in pneumothorax or even when both tamponade and pneumothorax coexist. I hope Achu, now you agree with me? You think there's a logic in my argument? Oh, thanks. Even though you were firm, but you are quite generous in accepting my argument. Thank you, Achu. How about other people? You also agree to my logic? Abhinav, Sakshi. All right. So Abhinav also thinks that my argument is correct. So this is called discordant amplitude changes. All right. We go to the next. Oh, this ECG I hope is clear on your screen. Yeah, so Achu is asking if both amplitudes are low, can be both or temporary? Yes, indeed. Um, uh, the tamponade can cause reduction in the QRS and the P wave amplitudes. Pneumothorax can cause, and if both of them are together, yes, definitely. Yeah. So you are right. Now, I hope this ECG is clear. Now, what is the response here? Is it an AV-Venki block? Is it a 2:1 AV block? Is it an unconducted PAC or a CHP? Okay, Abhinav is telling choice number 2 as a 2:1 AV block. Sakshi says CHB. Achu also saying CHB. That's very nice. Okay, so Achu, can you tell why you are in disagreement with Abhinav? Or Sakshi can say why this is CHB and not 2:1 AV block. Very nice. Achu told perfectly the right thing. There's a change in PR and the AV dissociation. That's perfect. Achu got 100% marks here. It seems like there are two P waves for one QRS. There are two P waves, one QRS. There are two P waves, one QRS, two P. However, what is important is how is the P and the QRS relationship, and actually had very well picked up the phenomenon of a changing PR interval. So just a coincidence that there are two P waves on QRS, but they are not necessarily related with those QRS. So the PP interval remained constant, and the RR interval is also remained constant and is exactly half of the PP rate, and that is why just a coincidence it appears that is a 2:1 AV block. The ratio is 2:1 correct, but this cannot be called as a 2:1 AV block, and hence Achu and now Abhinav also agrees that this is CHD. Well done, everybody. So not mention the age, is again a young boy. So I am waiting for some responses. I'm surprised why nobody is responding. Okay. Sheikh Amira, pacemaker is indicated. Abhinav says pacemaker indicated. All right. So now, looks like both of them are in agreement with the diagnosis of CHB. Why is CHB again like in the previous case? You do not have a P to R relationship. There are more P waves than QRS. PP interval is constant and RR interval is also constant. Yeah, it qualifies for a CHB. When a CHB ECG is shown without any more details, the next thing what you would see is the ventricular rate. If the ventricular rate, for example, here is about 50 to 60, for example, and if the QRS is narrow, access is also within normal limits, it's suggestive of a congenital complete heart block. In the absence of several more parameters, just on the basis of this ECG, one cannot say or one should not recommend a pacemaker. The ECG, which is suggestive of a congenital complete heart block, warrants further investigations and history taking to recommend a pacemaker therapy. For example, is the patient symptomatic? How is the underlying heart? Is there any ventricular dysfunction? Is it associated with a congenital heart disease? These are few of the questions which need to be addressed. If one sees congenital, one sees ECG which is suggestive of a congenital CHP, wherein the QRS is narrow and usually the escape ventricular rate is 50 and above. So only on the basis of this, saying pacemaker indicated is too enthusiastic. If the patient is asymptomatic and there's no structural heart disease, and then maybe if you make him run on a treadmill, if he achieves good chronotropic response, pacemaker may not be indicated. And hence, the correct answer for this is pacemaker may not be indicated. Allopant usually does not serve any purpose. Occasionally, in congenital CHB, it may increase the ventricular escape, but that cannot be used as a therapy for a person who is either asymptomatic or he has symptoms. So one should avoid using allopant in complete heart block cases. So, Achu had written the right answer here. Pacemaker may not be indicated. So, Achu, did you agree in what was I saying? That the congenital CHP ECG alone is not necessarily an indication for a pacemaker. Very good. So, I hope everybody is now in agreement. Now we go to the next. The questions remain, the choices remain the same, only the ECG changed here. Okay, so I think there is an unanimous response here that everybody is in agreement that in such a patient, one should strongly recommend pacemaker because this is also a complete heart block. There is no relationship between the P and the QRS, and even though there is a slight change in the PP interval, it can still be qualified as a complete heart block. And what is important is the escape rhythm is associated with a wide QRS. If there is a wide QRS and if the rate is lower, and if you think it is the CHP, which is most likely in this case, even though I was pointing out that the PP interval is changing, even if the person is asymptomatic, one cannot rely on such ventricular escape rhythm, which is characterized by wide QRS and a very low rate. So here, even if the person is asymptomatic, pacemaker is strongly advocated. So now, this is another athlete. In fact, state badminton championship she had won, and now she complains of fatigability and giddiness. I think you're all aware of this abbreviation. CMRI, it's a cardiac MRI, maybe contrast enhanced. The recent yoga day, I thought might also inspire her as a therapy. That's why I put yoga and meditation. So may I request some responses here? No? Achu would like to put a pacemaker. May I ask Achu, why is that? Why do you want a pacemaker? You are not aware of yoga meditation benefits? Long sinus pause. Yeah. Yoga does not help there. Achu. Did you participate in the yoga day or no? Yes. So anybody else? Shakimira, so CMRI, oh, okay. So Sheikh Amira, can I ask you, why are you saying a cardiac MRI can be okay here? What could be the reason for your MRI recommendation? Okay. See, identify reason of bradycardia, probably HOCM. All right. HOCM, then the cardiac MRI is not an investigation of a choice. And MRI would not tell you about the reason for bradycardia most often. Okay, so MRI is not the right answer. Okay, now, see, if the patient has fatigability, giddiness, and if you think on your clinical examination, if the patient has bradycardia, I think, especially the symptoms of a recent onset, but I think it is quite wise to advise the Holter. But when you advise a Holter and then you find out some bradycardia episodes, your attention then should be towards what was the time of the day when this bradycardia was recorded, which is usually available on a Holter trace. Now let's focus our attention here. It is midnight, around 1 a.m. midnight. We already know this is an athlete, well built, practicing badminton so aggressively that she won the championship. So there is a high vagal tone that is expected in this girl. The vagal tone gets more intensified in the night hours. And that might actually be a physiological response. This bradycardia can be a physiological response. This cannot by itself explain the fatigability and the giddiness. Well, now there is a pause here. And the length of the pause is written here as 2 seconds. On a Holter monitoring, if you have a pause up to 2 seconds and there is no other periods where the pause exceeded more than 3 to 4 seconds, these pauses of a shorter duration can also be considered as physiological. Whenever you see a pause, you need to also figure it out what was that the pause due to. Well, there is a P wave here and there is a P wave here. One can consider this as a sinus pause. However, what was happening before? There was one P wave here, there was another P wave here. And when maybe the P wave preceding to this could be at the same time. So there was a P, there is a P, there is a P. You expect another P coming here. But this P wave occurred earlier. So this is a PAC, premature atrial complex. And this PAC made the next sinus come later. So this pause is also considered physiological. So in the presence of a bradycardia, a PAC may make the pause look really long, and then it may cause a concern. However, when you subject the patient for a Holter, especially during the evaluation of the bradycardia, especially in an athlete, we should remember that heightened vagal tone, typically in the night, may cause sinus bradycardia, may cause prolonged PR interval, may sometimes cause AV ventricular block, may sometimes can cause 2:1 AV block, and typically if there is a PAC, there can be a long pause. So all these are not actually contributory or cannot be just considered contributory to her fatigability and giddiness. Who knows, when she gets up in the morning, such episodes may not be there. Who knows, when she actually runs on a treadmill, she may achieve good chronotropic response. And then we just discussed MRI is not going to be a investigation of choice, especially when the bradyarrhythmia is an issue. Rarely a circuit, an MRI can help, but in this patient where there is no history, MRI may not be the ideal choice. We have not yet figured it out what is the reason for fatigability on the basis of this, and hence pacemaker cannot be advised. Now, how about yoga and meditation? I think they really improve the health, longevity, peace in general, in the surrounding. But one should remember that yoga and meditation further enhance the vagal tone. So sometimes if you think the bradycardia and the AV blocks are the reason for fatigability, you actually do not advise yoga or meditation. In fact, if a person is pursuing high intensity yoga and meditation, it may make sense to advise to go slow with respect to these two activities, where the benefits mostly are related with resultant bradycardia and heightened vagal tone. So there's one particular arrhythmia where you may advise to go slow with respect to yoga and meditation, is the arrhythmia that are associated with bradycardia. So the answer here is none of the above. I hope Sheikh Amira and Achu are okay with my reasoning. All right. So thanks very much. Now, Kavita must be around. I am going to be showing a couple of more if you people are okay. ECG in the similar lines. Not much history is given. It is just that you will have to describe the findings of this ECG. Achu, Sheikh Amira C, A.V. Venki Bach, Abhinav, A.V. Venki Bach. I think you people are quite correct. No, Sheikh Amira, the reasoning is incorrect, even though your answer is correct. The reasoning is not correct. What you could have mentioned here is gradually prolonging PR interval, not prolong the PR interval. Excellent. Yes. Now you rectified yourself. Progressively increasing PR interval with a missed beat is what is seen on this ECG. Excellent. So it is not fixed prolonged PR. There's a gradual prolongation of the PR, which is the hallmark of the A.V. Venki Bach. Perfect. I think you got the right point when we had discussed earlier that 2:1 A.V. block, which actually is not 2:1, but it was CHB. If the same principles, if they are adopted here, you will not miss the diagnosis. Well, 3:2 A.V. block is not 3 P waves and 2 QRS. A 3:2 A.V. block is 3 P waves, 2 QRS, but fixed PR. That is what is 3:2 A.V. block. A 4:3 A.V. block is not simply 4 P waves and 3 QRS. It is 4 P waves, 3 QRS, and the PR intervals fixed. Here, the PR intervals are not fixed. They're gradually prolonging, and as Sheikh Amira says, there is a beat which is missed. So you call this as gradually prolonging PR and one missed 3:2 AV Venki Bach. So this sequence is called 3:2 AV Venki Bach. And how about this? 1, 2, 3, 4. 4 P waves and 3. See, this is not 4:3 AV block. This is 4:3 AV Venki Bach. In the earlier ECG, I also showed 2:1 AV block, and I had told it could be type 1 or type 2 MOBIs. That means it could be just 2:1, or it could be 2:1 AV Venki Bach as well. Apart from that, in any one of the situations where you have more P waves and the QRS, we have to figure it out whether there is any kind of a relationship with the P and the QRS. Whether the PR interval of a conducted QRS, is it fixed or it is gradually prolonging. So this is classical AV Venki Bach of 4:3 ratio, and this is 3:2 ratio. In a typical AV Venki Bach, you have the maximum increase in the PR interval is in the second conducted PR, and later on, even though if the third PR is prolonging, the amount with which this PR is increasing is less than what was the increment was seen in this. So that is called decremental increment in the PR interval, which is called a classical or a typical AV Venki Bach. So here the answer is AV Venki Bach. Alright, we take the last one here, which is again similar to the earlier two ECGs what we discussed. This is a 15-year-old boy who had syncopal episodes before the patient came to the hospital. Okay, Sheikh Amira now says it's LBBB. Abhinav says none of the above. It doesn't, Abhinav, you do not like those abbreviations, or you have a reason. Why is that? Why do you say it is none of the above? If it is none of the above, can you actually tell us what actually it is? What is the diagnosis? Excellent. Why do you say it seems like pre-excitation? Why don't you say it is pre-excitation? You still are doubtful about the pre-excitation, or it is pre-excitation? That is how you will become an expert in reading ECG. I really liked when you say seems like pre-excitation. I always like if a person makes the statement that it may be, it can be, because ECG can be misleading. I think humility is what is required, to be considered good in ECG reading because there are always differential diagnoses. So I really liked when you said it seems like pre-excitation and you hesitated to say that it indeed is pre-excitation. You're right. So now sometimes what happens is in isoarrhythmic AV dissociation, the P wave may fall on the QRS, and if the QRS is already a little wide because of the underlying intraventricular conduction defect, the close proximity of the P waves and the QRS may actually make you misdiagnose the rhythm as pre-excitation, where actually it is isoarrhythmic AV dissociation. Here, you are right. It is most likely a pre-excitation. You have a short PR interval and a delta wave. A short PR interval and a delta wave. So, a wide QRS. Sheikh Amira is correct saying that it appears like LBBB. So, if you have a short PR and a wide QRS, and the wide QRS is also marked by the slurring of the initial 40 to 60 milliseconds, what we call delta, it is most likely it's a pre-excitation. LBBB kind of a pre-excitation is suggestive of a pathway being on the right side. So this is a right-sided accessory pathway, represents as a left bundle branch block. As I had mentioned earlier, pre-excitation may give rise to the appearance of a right bundle branch block, in this case is a left bundle branch block. Earlier I had shown a pre-excitation may give rise to an appearance of a large amplitude QRS, suggestive of a ventricular hypertrophy or a biventricular hypertrophy. A pre-excitation may also give rise to STT changes in the form of either ischemia or infarction, and sometimes the Q waves may be because of a negative delta wave, and then it might appear like infarction. In any case, in this 15-year-old, the clinical probability of a myocardial infarction or coronary artery disease is low. So the logical choice could have been LBBB, provided you have a near normal PR interval and no slurring of the QRS. So Sheikh Amir started seeing some delta waves. In fact, it is not in some leads. The delta waves are globally present. Wherever there is a QRS, you see the slurring of the initial component of the QRS. So this ECG is characterized by short PR, wide QRS, delta wave, left bundle branch block morphology, and hence most likely the accessory, this is because of pre-excitation due to accessory pathway residing on the right side, and it is mimicking like an inferior wall MI, loss of R waves in couple of leads of inferior area, and loss of R waves in V1 and V2, V3 appears like mimicking like anterior wall MI. So the right answer here, now I think everybody got it, and that is none of the above. So these were the ECGs which I thought I should discuss with you. We discussed some pre-excitation patterns. We discussed some bradycardia and one tachycardia. So I enjoyed. I hope you learned a few points. Let me know if you have any questions.